Good afternoon,
Hello.
everyone, and thank you for attending today's webinar, Telemedicine and COVID-19. Take care of your patients while allowing them to stay at home, presented by Nancy Enos with Enos Medical Coding. Please be aware that there will be a question and answer portion at the end of today's webinar. You may type your questions in the question box located on the right of your screen, and they will be answered in the order received. Additionally, if you would like a copy of the presentation slides as well as a few other handouts, they are available in the handouts section on the right of your screen. They will also be emailed to all participants following the completion of today's webinar, as well as a recorded version will also be available on the website for members only. Again, we would like to thank you all for attending, and I will now turn things over to Nancy.
Hello, everybody. Happy first day of spring, and thank you for joining us on this telemedicine COVID-19 webinar. As Bria just said, we do have a lot of reference material available for you to keep after the presentation. There are so many questions that you might have. I included a list of all the CPT codes that are covered by Medicare telehealth, how much you get paid for them. There's a different document that gives the reimbursement for the new telemedicine codes. We have a very comprehensive frequently asked question document for you that might answer any questions that you might have in the typed in area today, as well as the PowerPoint slides. That being said, the next 30 minutes I'll go over each of the slides in detail. And if you want to hold off on your questions before you start typing them in, you might find that within the next 15-20 minutes, that question was answered and it won't be necessary to submit it. But certainly if I do raise any questions or if you have any questions at the end, I'll go ahead at that time and type them into the sidebar and we will go through them in the order that you've submitted them. That will make it a little bit more efficient in avoiding redundant questions and holding you up today. I know that your practices might be extremely busy at this time. Okay, let's get going. If you were familiar with the telemedicine codes prior to Tuesday of this week, what I am going to tell you in the next hour might be very confusing and conflicting to your previous telemedicine knowledge. And what I'm going to ask you to do is take that knowledge that you had, put it in a shoebox and put it up on the shelf, because it's not going to reconcile with what we're going to be talking about today. With these exceptions to all the rules, we're giving you new information. And if we take this with an open mind, it'll be a lot less confusing to everybody. What I'm going to tell you is information that I have worked on all week with my colleague Claire in the MGMA Government Affairs Office in Washington, D.C. I work as an MGMA consultant as well as a private consultant working on coding issues. And this has been a very quick evolving, very dynamic week for us, learning all these new regulations and clarifying some of these things. So if we have any questions at the end, I certainly will get the answers for you and update. What we're going to tell you is information that is based on CPT and CMS guidance and the new rules that have come out this week. But we know that you have contracts with local payers. Payers have their own rules, so it's up to you to check with each of your local payers that you have contracts with and lay their policies on top of this information and then formulate an operations plan that's going to help to get you reimbursed as fairly and quickly as possible. I'm also going to be talking about some of the different types of providers, mid-level providers and non-physician providers, and the definition of a non-physician qualified healthcare provider also varies by state. So it's up to you to know through your state Department of Health what the scope of practice and licensure is for allied health professionals in your area, as well as in your own group practice, what your credentials are for each of those practitioners and if you're able to bill for them. So some of those questions I can't answer for you because they might be local and they might be payer specific. So we'll keep this more generic in terms of the information that we have from CMS. On Tuesday of this week, March 17th, 2020, the Centers for Medicare and Medicaid issued the guidance that came from Health and Human Services Secretary Azar. He waived a lot of the restrictions for billing Medicare telehealth in an effort to help keep people at home and help patients get over this virus by not exposing them unnecessarily by having them come to your office. The effective date for all of these regulations is backdated until March 6th. So if you've done qualifying telemedicine visits, as we're going to be describing today, you actually can go back and bill for them as long as they were medically necessary and documented. You can get reimbursed for those as well. And again, make sure that they comply with other payer policies, although we are seeing a lot of commercial payers today getting on board with the CMS guidelines quite quickly. One of the things that they waived with the telemedicine restrictions is the geography. Now a patient can be anywhere. Patients can receive telehealth services in a non-rural area. Previously, they were restricted to rural and HIPSA areas. The location of the patient at the time of the service has also been waived. The waiver temporarily eliminates the requirement to have the originating site be a physician office or healthcare facility. The patients can now be in their own home or anywhere at all for that matter. The communication technology used has been waived, but it's not as simple as a phone call. The covered healthcare provider wants to use audio or video communication to provide services using any non-public facing remote communication product that's available. So the waiver does allow for smartphones as long as they have audio and video capabilities. Without video, it's just a telephone call, and we will go over those telephone call CPT codes. The real-time communication rule regarding telemedicine says that the provider must have an interactive audio and video telecommunication system that permits real-time communication between the patient at home and the provider. So under this context, now the provider and the patient must be able to communicate using audio and video such as FaceTime. The Health and Human Services notice, however, does specify that Facebook Live, Twitch, TikTok, other similar video communication applications that are public facing should not be used in the provision of telehealth by covered healthcare providers. So make sure that it is private and secure and use your best judgment on that. The Office of Civil Rights is the governing body that oversees enforcement of HIPAA privacy, and they have said that they will not impose penalties for non-compliance with the regulatory requirements under the general HIPAA rules that were previously in place, as long as a good faith provision has been made under the COVID-19 public health emergency. And this notification was effective immediately on Tuesday. And in your handouts, the frequently asked question document does have links to all of the government sources that I'm going to be talking about today. During the COVID-19 national emergency, the rules just may seek to communicate with patients, provide telehealth services through remote communications. Some of these technologies and the manner which they're used by HIPAA covered healthcare providers might not fully comply with the usual HIPAA rules, and there's an excuse for that now. You're excused from doing that. But some larger healthcare systems or your practice might be more sensitive to their HIPAA rules, and you might want to seek additional privacy protection for your telehealth while using video communication products. And you can do that if you feel safer by using a HIPAA compliant business partner, someone who's a technology vendor who is HIPAA compliant, and have them sign a business associate agreement with you. Some of the specific examples of such vendors from HHS were mentioned: Skype for Business, UpDocs, VC, Zoom for Healthcare, DoxyMe, Google, G Suite Hangouts, or Meetup, those kind of products. And I'm sure that there are many more that you could opt to use if you feel more secure going that route. The providers who are eligible to provide telemedicine to patients to keep them in their homes at this time is doctors, nurse practitioners, physician assistants, nurse midwives, certified nurse anesthetists, clinical psychologists, licensed clinical social workers, registered dietitians, and nutrition professionals. they're all able to offer the telehealth. And when we get to the covered codes in a moment, you'll see that the typical services that they provide match up with the licensed providers. And again, make sure that you are checking your state regulations as to scope of license and licensure for these allied health professionals. The types of services that will be reimbursed for telehealth, even if unrelated to the treatment of COVID-19, diagnosis, screening, or treatment, the intent here is to keep patients out of your office and in their home. So it can be for any reason the patient is seeing you. There are 101 CPT codes that are designated as eligible for telehealth payment, and I have put them together in a list, and that is one of your attachments. They cover all the CPT categories of office and outpatient visits, subsequent hospital and nursing facility visits, psychotherapy, health and behavioral assessment and interventions, end-stage renal diseases. In previous webinars, we had a lot of questions about doing well visits remotely, and because the physical exam is the major component of those services, they are not on the list of approved CPT codes for any age. Medicare telehealth services are generally billed as if the patient had been in your office and the service was furnished in person. And this is the really big deal here, because your reimbursement for your telehealth services, starts with some of these codes that offer $14, $12 for some of the reimbursements for the lower level out of 3, going into the $20 or $30 range. Now, you're going to have the opportunity to bill for your E&M services, which are significantly higher, even though you're canceling your appointments or the patients are canceling their appointments to keep them at home. If you perform all the work of that evaluation management service and document it as such, and we'll chat about that in this session, then you can actually get paid for the office visit and not the phone call. So that is really going to help our practices from struggling with reimbursement during this time. The thing that's going to tell Medicare when you bill a 99213, for example, that it was a telehealth service and not an inpatient office visit, is you're going to change your place of service code from 11 to 02, indicating that it was a telehealth service, even though it doesn't match up with the office visit code. And that is the instruction that we've been given as of Tuesday from CMS, and that's going to help identify this as a telehealth service from a distant site, and the patient's at a distant site. The good news, Medicare is going to pay the same amount for the telehealth service as they would have if the service was furnished in person. For services that have a different rate, the facility versus the office, the site of service differential, Medicare is going to use the facility payment rate when the service is furnished via telehealth, and that will help defray some of the cost of using the platform if you choose to do that, because the facility fees are higher. Some of you might be wondering how you're going to collect a copay if you are going to be providing and billing an office visit when the patient's not at your front desk to pay their copay. And waiving the copay in the past has always been a compliance issue. It's been on the list of things not to do for fraud and abuse, but that has been waived as well, because the OIG is writing these rules to provide flexibility for you to provide telehealth visits. So you have a choice to completely waive the copay, to reduce the copay, to bill the patient and wait for them to send you a check, to collect it at their next visit, or to come up with an electronic means where they can pay you that fee online. This slide is not saying that copays have to be waived. You certainly have the right to collect the copay. It's just telling you that it's not going to hold you back or get you in trouble if you don't have a way to operationalize office visits electronically, because you don't have a way to get that out-of-pocket cost collected because the patient's not coming through your front door and checking in at your front desk. Regulations for new patient versus established patient are also being relaxed. So the new rules do not enforce that an established patient has to have seen the provider within the last 3 years. Now, if you're going to be billing for new patient codes with 99201 to 99205, They might be more problematic in terms of documenting the elements of the service because you're required to have all 3 out of the 3 elements of history, exam, and medical decision-making documented in order to bill a new patient code. However, you have the alternative of billing based on time, and in all instances, I would strongly encourage you to document time spent. Many of these phone calls, many of these e-visits, many of these virtual check-ins and so forth, they all have a time component. So I would suggest 2 things, and everybody can jot this down right now. The first thing is the first sentence in these SOAP notes should say, this visit was conducted virtually with the doctor and the patient on audio and video technology via whatever it was, cell phone, Skype, you name it. The last sentence on the note should always be a statement of time spent. It does not need to be expressed from 3:17 p.m. to 3:27 p.m. It could be 35 minutes spent is a statement, and that is acceptable as well. But it is really important to make sure, especially with your new patients, because you can't do the physical exam. So you're not going to be able to satisfy a 99203 or 99202 without any exam, unless you're really good about documenting time. Another code option that you have, and it was available even before this waiver authority, was for the virtual check-ins and the e-visits. These were introduced last year. Medicare makes payments for these brief communication technology visits. These are short patient-initiated communications, so it's not the office reaching out to the patient, but it's the patient reaching out to the healthcare practitioner. And Medicare pays separately for e-visits, which are non-face-to-face patient-initiated communications through an online portal. And that can be via email. I've heard some people talking about, well, can you use a text or anything like that? But there's no way to store that. So I would check with your HIPAA privacy policies and stick to things that can be stored, such as secure email and patient portal. The new codes I just mentioned are for the virtual check-ins, the G2012. This is a brief communication technology-based service by a physician or other qualified health professional. So other QHP would be a nurse practitioner or a PA, not a nurse or someone who's not a licensed clinician, who can report evaluation management services provided to an established patient not originating from a related E&M service provided within the previous 7 days, nor leading to an E&M service or procedure within the next 24 hours or soonest available appointment. There are 3 codes in this range. The first code is 5 to 10 minutes, and the national average Medicare payment for this is $14.80, just to give you a sense of how much the reimbursement is. The next code is G2010, and that is for the store and forward a remote video or recorded image submitted by an established patient. Some of those are for cardiac patients, and those are also going to be not related to an E&M within the previous week, nor relating to an E&M or procedure within the next 24 hours or soonest available appointment. And the reimbursement for that is $12.27. One of the other things we're talking about today is modifiers, and on these codes in particular, Medicare is currently waiving all telemedicine modifiers. Usually, modifier GT would pertain to these codes, and other payers might require the GT modifier. Virtual check-ins pay professionals for brief 5 to 10 minute communications that mitigate the need for an in-person visit. The visits furnished via Medicare telehealth is treating this patient the same as an inpatient visit. So knowing whether you should use the virtual check-ins versus the E&M codes for 99213, one really heads off the need for a visit, and the other substitutes for a visit. And the way that you can tell that the 99213, for example, has been done remotely is the place of service code 02 to indicate the service was performed via telehealth. An e-visit is when the beneficiary communicates with the doctors through the online portals. Medicare has a quick summary of their telemedicine services on their website, and I took a snapshot of it here. The 3 different types of services are the Medicare telehealth visits, And the services are a visit with a provider that uses telecommunication systems between a provider and a patient for the Medicare telehealth. The common codes are 99201 to 99215 or G0425 through G0427. And you'll have all of this in your handouts in detail. G0406 and G0408 for follow-up inpatient telehealth consultations. And then the relationship with the patient, these are for new or established patient because of the legislation 1135 waiver. New patients are now included in that top row of the sheet. The middle row talks about the virtual check-ins, and those are the brief 5 to 10 minute check-ins with your practitioner via telephone to decide whether an office visit is needed or not. So the codes there are G2012 and G2010. Those are for established patients only. And the e-visits are the communication between the patient and their provider through the online portal. There are 3 CPT codes, 99431, 99422, and 99423. And then there are 3 G codes for Medicare, G2061, G2062, G2063, and those are for established patients as well. My reimbursement for telemedicine handout that is going to be attached for you will give you all of the fees that are associated with these codes and a brief description for reference. E-visits for clinicians, clinicians who may not independently bill for evaluation and management, for example, physical therapists, occupational therapists, speech language pathologists, clinical psychologists, they can't use a 99213, so they can provide these e-visits with G2061, and that is for a qualified non-physician healthcare professional for an online assessment for an established patient up to 7 days. So it can be cumulative time over the course of a week. If it adds up to 5 to 10 minutes, the code is G2061. If it adds up to 11 through 20 minutes for the week, it's G2062. And if it adds up to 21 minutes, it's going to be G2063. And I did jot down at the end of those code descriptions the national Medicare average reimbursement, just for your reference so you can have an idea of the value of those codes, although your payer contract certainly may differ. Physician telephone services. As I've tried to stress a few times, all of the E&M codes and the telemedicine codes that are being relaxed, that you're allowed to bill as if the patient was in person in your office, must be accomplished by both audio and video capability on the part of the patient and the physician. For calls without video capability on either the provider or patient, then you merely have a phone call. So then you can use the 99441, 99442, and 99443 codes that are for physician or other qualified healthcare professionals, such as a nurse practitioner or a physician assistant. And that's going to be for telephone calls that are not originating from a related E&M service provided the previous 7 days, nor leading to an E&M service within the next 24 hours or soonest available appointment. And the 3 codes are based on the duration of the call, 5 to 10 minutes, 99441, 11 to 20 minutes, 99442, and 21 to 30 minutes, 99443. And the national average Medicare reimbursement is shown here, again, for your reference. When the telephone assessment is made by a qualified non-physician healthcare professional, it could be a nurse, it could be someone else in the office, such as a physical therapist, to establish the patient, parent, guardian not originating from a related assessment and management service provided within the previous 7 days, nor leading to an assessment and management service or procedure within the next 24 hours. The increments of time here are also 5 to 10 minutes, 11 to 20 minutes, and 21 to 30 minutes, and the reimbursement is shown here as well. So we have a lot of portal communication, a lot of phone communication, but what I really want to jump into next is when your qualified healthcare professionals, your doctors, your nurse practitioners, your physician assistants are actually doing an evaluation management visit remotely in lieu of having the patient come into the office. It can be billed with the 99212 to 99215, 99201 to 99205, depending on medical necessity, the extent of documentation, and time. So I'm going to spend a few minutes going over the documentation requirements for the SOAP note. And it's really important because I think practices are in the habit of using the telephone notes section of their EMR for these types of services, but they're actually going to have to open a visit and do an office visit note. And the top line is going to have to say this was conducted remotely, and the bottom line will have to say the amount of time. But the note has to be a SOAP note. It has to have a history and medical decision making, because those are the two key components that you can meet out of the three, or use your time statement to base on time services. And to optimize your billing, you should think carefully before just defaulting to time, because a provider can very efficiently take a detailed history and come to a moderate complexity of medical decision making in less time than it would take to meet the time threshold of 25 minutes, let's say. So sometimes it's easier for the doctor to do the level of service based on the documentation in the SOAP note and not the time statement. I've worked for CMS doing some auditing in the past, and they taught me that you have to weigh the note based on both criteria, documentation and time, and then choose your code selection based on whichever is more advantageous to the provider. So that's very good news. So now let's take a look at this note. It's going to have a history, it's going to have an assessment and plan. They won't be much in the level of exam because the patient's not there. You're going to be looking at them on video, so the doctor could certainly make a statement of the patient's general appearance. But the history of presenting illness does two things. It documents the extent of service, trying to get to the expanded problem focused or detailed history. It also establishes medical necessity for the service to be paid by Medicare at all. So what the patient is complaining about, how they're describing their chief complaint, is called the history of present illness. Details about how long it's been going on, the pattern of frequency, what makes it better or worse, the context, what brought it on, associated signs and symptoms when they experience the chief complaint, can all be noted in the starting sentence of the visit. And then if there are only 1 to 3 elements, that's going to be brief, and the most it will support is a 99213 or a 99202. Extended HPI will support a detailed or comprehensive history, and that's enough to give you a 99214, 99215, or 99203, 99204, or 5. After that, the clinician would ask the patient how they're feeling otherwise related to the chief complaint. So filling out a boilerplate 14-point review of systems doesn't necessarily ensure that each item on that list was medically necessary and related to the chief complaint. So be careful not to over-document your review of systems or have a clone note here. Just the systems that are experienced when the patient experiences the chief complaint. For example, a headache that's so bad it brings on nausea. And the level of review of systems problem focused for 99212 is none. Expanded problem focused to support a 99213 needs 1 system pertinent to the problem. Detailed review of systems to support a 99214 requires 2 to 9 systems, so just a second system that's related, using my recent example of a headache and nausea. And then complete is required for your 99204, 99205 for those new patients. And sometimes you can do the all others negative statement as long as the patient has been queried all the other systems. The past family and social history should be discussed as clinically pertinent. Past history could include their medications or recent illnesses. Family history would be important, especially if there are conditions related to the chief complaint that run in the family. And social history, reviewing such social factors, anything in the patient's lifestyle that would impact the patient's health, and particularly in the setting of COVID-19, you would ask about exposure and travel, and that would be considered social history. Putting it all together to calculate the level of history, you go across the columns and choose the level that has the least amount of documentation of HPI review systems and passive and social. So again, looking at the right-hand column, problem focused 99212, expanded problem focused 99213, detailed 99214, comprehensive 99215. Going on to the statement and the assessment and plan, we're going to just jump over the objective because there isn't really a good way to do a hands-on objective exam by the clinician. I've been reading some things about patient doing their home blood pressure measurement or taking their temperature, and there's certainly enough technology today where they could record a few things, but you wouldn't get beyond vital signs and general appearance. So the documentation for the assessment and plan is important in terms of documenting the number of diagnoses. They should be specific. If there is no confirmed diagnosis at the end of this audio call, report the signs and symptoms. And if there are tests reviewed or tests ordered, we'll go over that in a moment. And then the plan should also spell out what the treatment plan instructions are to the patient and what the level of risk is. So your note will then be calculated for scoring the complexity of medical decision making by taking into consideration how many diagnoses and how much data by using the following algorithm. And this comes from the Marshfield Clinic guidelines, which are going to change in January, by the way, with the 2021 E&M changes. So as soon as we get through this storm, there's another one coming. But we still are functioning today under the 25-year-old 1995 guidelines. So I'm sure that this is pretty familiar to everybody on this call. The box where you tick off the number of diagnoses that are in the assessment, not counting things that are just dragged down from the problem list and not addressed in the history or the plan. The next box is going to give us the score for the doctor's work in reviewing the results of tests in the lab, radiology, or medicine areas, or deciding to order tests in those areas, 1 point per category. And discussion of the test results with the performing physician should be documented in the assessment and plan, as well as plans to obtain history or summarization of history obtained, and independent visualization of images tracing specimens by the clinician also should be documented in this area, and that can sometimes bump up the level of complexity of medical decision making as well. Last, we have the table of risk. This is a condensed version just for purposes of the webinar. There's a column missing, but most often we find something that is appropriate for the level of service. Minimal 99212 is over the limited problems with reassurance, rest, gargles, superficial dressings. Low would support a 99213, and those are 2 or more self-limited problems, 1 stable chronic illness such as hypertension, diabetes, or 1 uncomplicated illness such as cystitis, allergic rhinitis, simple strains, sinus infections. Those kind of things might be treated with over-the-counter drugs, or even a prescription. They would still be uncomplicated and considered low for 99213 or 99203. Moderate risk gets us to a level 4 if the assessment and plan has 2 or more stable chronic illnesses, an undiagnosed new problem with an uncertain prognosis, an acute illness with systemic symptoms, and an acute complicated injury. The treatment discussions would include elective surgery, prescription drug management, writing new scripts, renewing recently prescribed drugs, adjusting drug dosages, or even discontinuing medications. High risk are the more chronic problems with severe exacerbation, progression, or threat to life. So anything in the high category, you might be talking about having the patient admitted to the hospital. Calculating the complexity of medical decision making takes all 3 of those calculations, and the row that has 2 out of 3 met or exceeded is going to support your complexity of medical decision making. And again, that's straightforward, 99212 or 202, low complexity, level 3, moderate complexity 4, high complexity 5. We don't need to worry about the greater than 50% of the time spent counseling, because time is really going to be a controlling factor. So for the time being, we can think about face-to-face time as FaceTime on the phone with the patient. So this is not going to really require that statement of greater than half the time was spent. And this is actually in line with the 2021 changes coming up next year for the selection of office visits, which are going to be exclusively based on either time or MDM, as long as an appropriate history and exam are written. So we will put that on the to-do list and learn more about that come fall, so you're ready for the January changes. So this is a snapshot of what you would be billing for these virtual office visits for the patient. The good news is it's not too hard to document the level of service here. You can bill time, you can bill this based on the SOAP note, and the reimbursement will be at the level you would have been paid as if the patient had come to the office. And it is certainly, higher than the other reimbursement for telemedicine. Using them both hopefully will keep your practice going through these hard times and help you out. Next, we'll talk about the telehealth modifiers. To begin with, CMS is not requiring additional or different modifiers associated with telehealth services furnished under these waivers. So Medicare says, don't worry about any modifier at all. Using the place of service code 02 is going to tell them that it was an audio and visual remote visit, and you don't have to worry about that. But some of the private payers might not be as generous, and they may be more stringent, and they'll want some of the GQ, GT, and GO modifiers, so I left them there for your reference as well. Other payers are using the 95 modifier, which is the synchronous telemedicine service rendered via real-time interactive audio and video telecommunication system. So if you're using a platform, you can use that code, and the GT modifier for other commercial or private payers might be used for your interactive audio and video telecommunications. Now, CMS has put out this guidance for all the Medicare plans, but states administer the Medicaid. So the states have been given broad flexibility to cover telehealth through Medicaid by HHS. They don't need any further federal approval. So make sure that you check in with your Medicaid in your state so that you know what accommodations they have made to change the payment methodologies to account for the telehealth costs during this time. So we've talked about the place of service, the procedure codes, who the providers are. The next thing you need on the claim is your diagnosis. And the diagnosis has to be supported by the documentation in your note. The E&Ms have to be there to tie in with the diagnosis code to support medical necessary for the extent of the service as well. Now, you can't have a level 5 with a hangnail, so those things should always be in sync. For patients under your care for chronic conditions that must be assessed, they have hypertension, obesity, COPD. It's pretty straightforward to know what their diagnosis list looks like. But for patients who come in, or who check in rather, and have a remote visit, they might have symptoms and there's no definitive diagnosis at the end of that virtual encounter. Just report the symptom codes for fever and cough, for example. There are no limitations for what diagnosis code you're reporting or for what reason the patient is being seen under these provisions. The statute was put in place to give telehealth flexibility without regard to the diagnosis. It doesn't matter what types of problems you're going to be addressing with this type of care. The critical point is, given the importance of social distancing and other strategies recommended to reduce the risk of COVID-19 transmission, which it will prevent the vulnerable beneficiaries from unnecessarily having to come into a healthcare facility. It's all about keeping everybody at home. So a beneficiary could use this to visit with their doctor virtually when they need a prescription refill. Otherwise, you have a diagnosis code for I-10 for a patient who needs a refill on their prescription for their hypertension medication. As long as it's reasonable and necessary, then it will be covered by Medicare. If the visit is related to coronavirus, there are some codes, but there are some restrictions here. On January 30th, the World Health Organization convened an emergency meeting and they created a specific code for the new coronavirus, which is U07.1. However, at this point in time, the effective date for that code is October 1st, 2020, although someone just mentioned that they heard it was going to be moved up to April 1st, and I made a note to check on that with MGMA Government Affairs, and we'll send out an update to that information if that is the case. There are some codes that you can use when a patient enters into care to seek counseling and screening. So the Z71.84 is if a person needs the counseling because they're concerned about coronavirus due to having traveled recently. And Z71.1 is the diagnosis code for a person with feared health complaint in whom no diagnosis is made and they're asymptomatic and they just want to talk about their anxiety and having a test. We used to call that the worried well, but I think in the current environment, it's understandable and it will probably be used pretty often. Other than that, you have the signs and symptoms diagnoses such as cough and fever that you would use based on what is documented in the note. So just to recap here, the key takeaways, you can make this and take this and implement it for calls and video conferences as long as there was audio and video and a note retroactive to dates of service March 6, 2020. The visits are going to be considered the same as in-person visits and are paid at the same rate as regular in-person visits. And this will exist for the duration of the COVID-19 public health emergency. Medicare will make payments for beneficiaries in all areas of the country and in all settings. While they must generally travel to or be located in certain types of originating sites, those restrictions have listed. They can be in their own home. The copay and co-insurance usually applies to all the services that we're talking about, but the Inspector General has given you flexibility. They're not saying that you must waive copays, but you have the option of waiving copays if it's problematic for you to operationalize your telemedicine care and worry about how you're going to collect the copays. To the extent that the Bill 1135 waiver requires an established relationship, you also can be assured that you're not going to be audited for that new versus established status for patients during this public health emergency. I do have a robust 12-page appendix that I put in here too, because you might have questions about telehealth other than this COVID-19. So I'm not going to discuss them because I don't want to cause any confusion. And if you can just put those in the shoebox on the shelf and we'll look at them after things get back to normal. Hopefully that is helpful, and we will pause at this time for your questions.
Thank you, Nancy. If anyone has any questions at this time, please type them in the question box located on the right of your screen. The first question we have is, for a level 3 established visit, how is the exam documented?
You cannot do an exam, so you don't have to. I would just put the history and then go right into the assessment and plan. Okay, and the next question is, we have Epic, and I was wondering how you can direct the POS 2 when they are a POS 11, 19, or 22. You'll have to talk to your system administrator about allowing you to choose a different place of service for this purpose.
Thank you. I may have missed this. Is POS 2 for virtual visits G2012?
Yes.
Notifying patients that we now offer this service, is there any legal language we need to use to send a SMS blast?
I've read a few things from CMS that are encouraging physicians to notify the patients of this option in an effort to keep patients at home and get the telemedicine up and running as quickly deployed as possible. I am not a lawyer, so I can't answer any legal questions. Go on the MGMA website. I think there's some information under government affairs that talks about marketing this and strategies for getting the word out to your patients. It's encouraged by the government for sure.
Okay. What CPT code would you use if it was just a telephone call and not FaceTime?
Okay, the telephone call is the 99141 codes we mentioned earlier, based on whether it's a physician or a non-physician. So the 99441 to 99443 would be codes reported if it's a physician.
Thank you. If we have a patient come in for x-rays and then do the visit by telehealth, do we bill the x-rays on their own or part of the telehealth visit?
I would consider that a different encounter because the patient is in the office once and then not in the office for the second. Given that it's a different site of service, I would separate that.
The 99441-443 does not show as an allowable under the 2020 CMS fee schedule. Are they now covered for the telephone visits?
I found those allowables on the Medicare, but I would have to check and find out if they're covered codes.
Okay, will Medicare now recognize and reimburse 99443?
That's the same question. I'll have to check and find out. I did get the allowable rates from Medicare, so they have a fee for it.
Okay. Any info on residents in a teaching facility? Can they provide telehealth services if a teaching physician is present?
We'd have to check on that. The codes are reportable, and if the teaching physician is in primary care, under the primary care exception, and seeing patients in the outpatient setting, that would be allowable.
Okay. Sorry if I mispronounced this. Can optometrists seeing patients for medical reasons use telehealth codes?
No, there are no optometry codes that are on the covered codes list.
Thank you. For commercial plans, we need to talk to each plan to know if modifier is needed and smartphones work for those also.
I would expect that smartphones would be acceptable for everyone. Keep a sharp eye out for payer bulletins. I'm seeing plenty of them being blasted out by the various payers that you're contracted with, so you'll probably be told exactly what their policies are, and that will include modifiers.
Thank you. Is there an easier way to find out the insurance company's rules rather than go to each specific ones? Wait times on the phones have been horrendous. We are providers for many PPO insurances.
I know that if we pose that question to the payers, they would say to check their provider portal. They like to direct you to their website and have you log in under the provider portal, and that's where they post all of their information so you can get it quickly.
The slides for codes 98966-68 indicated in parentheses nurse. Would this be for RNs also?
Yes.
Do we use POS 02 for EM codes as well?
Yes.
Okay, are commercial payers generally preferring modifiers GP or 95?
I've seen both.
Thank you. Will MIPS for telehealth visits be waived? Do physicians need to report on all MIPS requirements?
You'd have to tell me in what context that MITS is.
Okay. Is it required to notify each patient of the costs before the visit on virtual check-ins and telehealth?
Well, patients should know what their coverage is, but it's always best, especially for your relationship with your patient and something unexpected like having it over the phone rather than be in the office. They would not be used to this. So yes, I would recommend that you notify the patient that they will be responsible for any copay, coinsurance, or deductible.
When can you bill for an RN? Please clarify.
With the non-physician telephone call codes, the 98966, 98967, and 68.
Thank you. Can you please confirm that telephone calls should be POS 02 and the e-visits portal are also POS 02?
That's correct.
What is the difference between 99441-443 and G2012?
G2012 can be through your portal, and the 99441 is telephone only. So it's a difference in technology. The virtual check-ins, though, the HIPAA G2012 does allow telephone or other device. So the G codes are generally accepted by Medicare, and the standard CPT codes are generally accepted by commercial payers.
Thank you. I have 992446-448 with allowable rates, so are these codes not billable?
446?
Yes, 992446-448.
And then 244. They're not on the covered CPT code list.
Okay, may PAs bill G2012 under Incident 2 if the supervising MD is in the building?
Yes.
Okay, if a physician uses her iPhone in FaceTime, can we use the 99212-214?
Yes, as long as the patient is also using the same technology affording video and audio. It has to be both ways.
Thank you. What were the telehealth codes billable by a nurse practitioner or physician's assistant?
G2061, 62, and 63. Those are on the reimbursement for telemedicine handout.
Are home health codes reimbursable via telemedicine under the new rules?
No, they are not.
For the telephone services, does the patient have to generate the call?
Yes.
Just to verify, we can see a new patient on a virtual or telephone platform?
Yes, under the exception to the rule.
Is it required for a patient to sign an authorization to be seen in video?
No, that is part of the OCR's waiver of the HIPAA rules.
Okay. To be able to use 99213, you must have both audio and video and use POS2?
Yes, both on the part of the provider and the patient. They both have to be on video as well as audio.
Okay. Do we need to use POS02 for commercial PPOs?
You have to check with each payer to find out what their billing instructions are, because this is a waiver that came through CMS and may or may not be followed by each individual payer.
Okay. On the claim form, what would be the address that should be assigned for the location of service? Can we bill with the office address still in box 32?
Yes, that's the physical location of the practice, although the O2 indicator will tell that it was remote and not in person.
What are the CPT codes for communication with the physician and patient through the EMR portal?
The e-visits through the portal are 99431, 99422, 99423. And for Medicare, you may report the e-visits with G2061, G2062, G2063. And that's in a grid on the second page of the reimbursement for telemedicine.
Thank you. For videos, can providers use any, not only HIPAA compliant?
It has to be private. It cannot be public facing, such as TikTok or Facebook Live or any other streaming service.
Okay, and the last question we have in here is, can we bill for a call when returning the call?
Yes, because you're returning a patient-initiated call.
Okay, thank you very much. So if we do not have any more questions for the day, then we can wrap things up. I'm sorry, we actually just had one more come through and then we will cap it. Does the physician have to initiate the call?
The patient has to initiate the call. Yeah, the patient must initiate the call. The physician can return the call if the physician isn't available when the patient initiates the call, but it all starts with the patient.
Okay, thank you so much, Nancy. Again, everyone, I will be emailing the slides as well as all of the handouts that Nancy had mentioned. And if you have any additional questions, please do not hesitate to reach out to Nancy directly. Nancy, we thank you again for putting on this great presentation, and I hope you all have a great rest of your day.
Thank you.